Yeah. Am I audible?
Yes, ma'am. You are audible. I will request all other participants to please. Sure, ma'am. Ma'am,
Yes.
we will start in another 1 minute.
Sure.
For all the participants, I would like to mention that Lalita ma'am is head of the department of critical care at St. John's, Bangalore, one of the busiest intensive care unit in India, which is not only doing patient care but amazing academic work with robust academic programs, with groundbreaking and revolutionary changes in practices are being made and also being taught to fellow pediatricians. It is a it is an honor and a privilege and a lot of respect for your time, ma'am. Thank you for taking our time.
Thanks, Dr. Nitin, for such an humble introduction. Can I start?
Yes, ma'am. Please start, ma'am.
Okay. Good evening,
Recording in
all.
progress.
Good evening, all the participants. Thank you for being here for the first session on understanding this mechanical ventilation. I know this being a Sunday, I know you have taken your time off to attend this program. It's not going to. I know that's to attend a program on a Sunday. It's not going to be easy, whether you are a participant or a teacher, but you have taken off time to be with us. That itself speaks large volume that you guys are keen on learning. Okay, so without wasting much time, today's session is going to be on mechanical ventilation. We are going to deal with physiology, terminology, different modes, and how to set and how to connect a ventilator. We know that mechanical ventilation is one of the important strategies to manage patients with respiratory ailments, whether it could be an acute severe refractory asthma or severe hypoxemic respiratory failure or a chronic conditions like chronic respiratory failure due to neuromuscular or muscular dysfunction. And mechanical ventilation is a cornerstone in a contemporary critical care. It's one of the life-saving in certain condition. So, but to understand, to even before attaching the mechanical ventilation, one need to understand the basics, the respiratory physiology, and as well as how a mechanical ventilation works. So, these objectives of my talk is a few slides on how lungs are ventilated naturally, how what happens when we connect a patient to mechanical ventilation. There are certain terminologies. Being a student, one needs to understand when you are dealing with mechanical ventilation is what is compliance, resistance, and time constant. This keeps coming up in most of the slides, even in the future talks. Also, what is this pressure, volume, and flow? How to set when we are connected to a ventilator? And what are the different modes of ventilation and setting up a ventilator? So, what happens in a normal respiratory physiology? We breathe from time to time, and there is nothing which says that we need to trigger a breath, we need to initiate a breath, we need to phase from the inspiration to exhalation, isn't it? So, respiration it's an automatic process, it's an involuntary. So, how does it happen? So, there are two types. One is external respiration, involves moving air in and out of lungs. This includes process involved in exchange of oxygen and carbon dioxide between the body and the environment. Okay, so this is external respiration. Internal respiration is something where the cellular uptake of the oxygen and production of the carbon dioxide within the cells. For this talk, we are going to deal only with the external respiration. So there is ventilation. Following which there is a diffusion of the gases like carbon dioxide and oxygen between alveoli and capillary. Then there is a transport in the blood vessels. So let's take these two scenarios. Okay, there is one 11-month-old child presented with history of fever, cough, cold, fast breathing, and this is how this child looks. The X-ray this shows hyperinflated, some streaky pattern, but look at the respiratory distress. Isn't he breathing very fast? He's almost there is an impending respiratory failure. But his x-rays are not that bad, isn't it? So there is another case, 8-year-old child, 5-day history of fever, cough, cold, and he comes with history of breathlessness. But look at his x-ray. X-ray shows right side complete opacity, but he is not having much of a distress. Okay. So why is such a difference between these two? An infant with bronchopneumonia versus a 8-year-old child. Why is this infant at high risk of respiratory failure as compared to the older child? We need to understand it. That is basically because there is an anatomical and physiological differences between a child or a bigger children or adult compared to an infant. There are a lot of anatomical differences. As we can see that your larynx is almost cephaloid, it's almost placed up, and the narrowest portion is subglottal region. As the child grows, the narrowest portion becomes at the vocal cords. And neck is very short, neck is lax, short, unlike in an older child or in an adult, where neck is quite strong and is able to support the head. Other differences are you are got in a small baby, it is circular or horizontal rib cages and the reduced ability of intercostal muscles. As a result, there is a reduced transpulmonary pressure, and these children, infants, are prone for collapse and atelectasis. The diaphragm insertion is also pretty different. It is horizontally placed, unlike in adults, where it is almost circular brace. And there is increased thoracic wall compliance. The thorax or chest wall compliance is highly compliant compared to adults, where in adults the chest wall compliance is less. So any obstruction, any infection, the small babies will start grunting when there can be active diaphragmatic contraction. And there are other subtle differences like lower proportion of type 1 muscle fibers, diaphragmatic fatigue, decreased FRC or inability to compensate FRC, and all these contribute to atelectasis. And as well as there is airway itself is so small. So any small obstruction, you know that the radius, any small obstruction, the resistance is inversely proportional to the fourth power of the radius. So the resistance increases, there is high chest wall compliance, and all this can lead to respiratory failure. In addition to, these small babies have got high respiratory rate, the work of breathing is high, they are metabolically very, very high with high oxygen demand. Hence, in the first baby with infant has high risk of respiratory failure compared to the older patient. So having understand these physiological and anatomical differences, let's look at what are the different type of respiratory failure. So these are the two cases. The first child has got respiratory symptoms, fever, cough, cold, rapid breathing, and saturation is 86% in room air. The second child, a 10-year-old child, presents with fever. There is no respiratory symptoms, but the child has got seizures and altered sensorium. And at presentation, he's got rapid, deep breathing, airways unstable. His saturation is also 86%. So can you see that this child has got respiratory symptoms and the second child has got neurological manifestation. But what is common between these two cases is both these patients are has got hypoxemia, 86% in room air, that is respiratory failure. What is the difference? It is the different etiology. The first child has got pneumonia, the second child has acute meningoencephalitis. So one need to understand there are two different types of respiratory failure. One is hypoxemic respiratory failure, like what happened in the first child where the respiratory symptoms are present, whereas the second is ventilation failure, where the neuromuscular or a CNS disorder can lead to ventilation failure. Both can present with hypoxemia. The first, these children will improve by administration of oxygen, whereas the second, the ventilation, by improving the ventilation, these children will require intubation and ventilation. As you can see, both have got hypoxemia. The first child has got PaCO2 can be normal or decreased because the child is got breathing very rapidly. So there is carbon dioxide washout, whereas in the second child, there is PCO2 build-up leading to hypercapnic ventilation failure. So one need to understand what are the different types of respiratory failure because the management differs. Even we intubate in the hypoxemic and ventilation failure, the settings, the mode, everything will differ. So one is very important to distinct between hypoxemic or ventilation failure. So as we can see that the main causes of respiratory failure are, it could be cardiopulmonary dysfunction, like a patient with pneumonia going on to severe ARDS and hypoxemic respiratory failure, or congestive cardiac failure with the respiratory distress can also develop with respiratory failure. Or sometimes if there's a problem from the brain, if, like, for example, neuromuscular dysfunction, or what you saw in the first child, the child with meningoencephalitis with altered sensorium had seizure disorder. So even they also can present with respiratory failure, sometimes very rarely. Or a patient with septic shock or sometimes with cardiogenic shock, they have increased metabolic demand, which is not able to meet the capacity. They also can present with respiratory failure. So how do you manage such a patient with respiratory distress or failure? So initially PaO2, PCO2, everything is maintained. So we have to treat them with simple phase nasal cannulas. Then if sometimes the PaO2 drops or there is these patients develop hypoxemic, then we can give a trial of CPAP or HFNC, or you can try NIV. But once the compensatory mechanisms fail, that's when these patients will start requiring intubation. When in refractory cases, in a late phases, if you miss identifying or recognizing these children in the compensatory mechanism, even before the compensatory mechanism fails, then the options are very, very lean options we have, and they may not even respond to conventional mechanical ventilation, and these children might need ECMO. So now we have understand how how we are ventilated naturally. Let's look at what are we going to do when we put a patient on mechanical ventilation. Remember, lung mechanics, irrespective whichever type of mechanical ventilator you have, you could be having Hamilton or Mackay or Nelcor, all of them have got same basic principle. We are going to mimic same as what respiratory physiology or naturally the way we breathe. So there are three parts of it. One is ventilator, the other one is tubing and humidifier. Ventilator mimics respiratory muscles for effective breathing. Tubing functions as the trachea for air passage, and humidifier act as a nose, humidifying the inhaled air. So it is it mimics almost similar to the normal respiration, where we can see ventilator, that respiratory muscle, tubings like trachea, and the humidifier is like acts as a nose. So there is nothing, or a big different principles in a patient in a mechanical ventilator. It is what to mimic the normal respiration. So mechanical ventilation depends on interaction of four parameters. One has to understand. So ventilator delivers a gas to the lungs using positive pressure at a certain rate. So there is a difference in the pressure which causes the gas flow over a period of time. As a result, what happens? The volume changes and the inspiration ends, and the cycling from the inspiration it is cycled off to exhalation. That's all. So you remember it interaction with the four parameter. The difference in the pressure causes the gas to flow. When the gas flows over a period of time, whatever set time you have done, the volume changes. Inspiration ends and the exhalation follows. So that is what happens. So, as I said, in mechanical ventilation, it mimics the normal respiratory physiology. Okay. So, how do we, what initiates a breath in naturally? Any signal from the brain due to any change in the pH or hypoxemia or hypercapnia, the brain senses, isn't it? So, as a result, the brain sends a signal to the stretch receptor, which is present in the lungs and the diaphragm. And so after the breath gets initiated, the lungs and diaphragm stretches. So and it gets limit to only one particular limit. It can expand. Then after that, cycling. The inspiration ends and the exhalation starts. So remember these three components. Trigger is nothing but initiating a breath. Limit is inspiration get limited either due to change in the pressure or volume. And cycling is inhalation stops or ends and the exhalation starts. So in normally what happens, the inhalation is always active process, isn't it? Similarly, even in the mechanical ventilation also, inhalation is active, where exhalation normally in you and me, it's always a passive phenomenon. Similarly or likewise, even in the mechanical ventilation, exhalation is always passive. So remember this TLC, trigger, limit and cycling. Why we need to remember? Whenever we are setting any mechanical ventilator, either a mode, we have to remember that what is the trigger we have to set, what is a pressure limit or a volume limit for the inspiration, and when does the inhalation stops and the exhalation starts. So this is similar to the normal respiration. But how to mimic physiology when on ventilator? We are not just dealing with the normal lungs, isn't it? Whenever you put a child on mechanical ventilator, it could be because of normal lung, or it could be because of any ideas of severe bronchopneumonia lung, or some obstructive like a foreign body, or some unilateral pathology. So, but the main aim or the goal is to target gas exchange without causing any ventilator-induced lung injury like volute trauma or a barotrauma. This should be our ultimate goal, irrespective of whatever etiology we are going to ventilate. So we have understood how normal respiration happens. What happens in a mechanical ventilation? It is almost mimicking the normal respiration with the trigger that is initiating a breath, limit, inspiration gets limited, and cycling. That inhalation ends and the exhalation starts. But is it the same for all sort of lungs? No. How do we know? We need to, before we move on to how to set up a ventilator for a different etiology, one has to understand what is this compliance, what is this resistance, and what is this time constant. Again, there is a scenario here. This is a 4-year-old child with severe status, acute severe asthma. We generally we don't intubate acute severe asthma, but this child presented with altered sensorium. He was almost becoming very drowsy and hypoxemic. And the baby did not respond to the inhaled bronchodilators. Remember, all bronchial asthma you do not have to intubate. You have to try simple face mask oxygen, then continuous nebulizations, then bronchodilators. Suppose the patient is not getting better, becoming hypoxemic and almost impending arrest, that's when you try to intubate these children. So this is what happened with this child. You can see the X-ray, which is completely hyperinflated, which happens in bronchial asthma. And when we started intubating, his peak pressures went high. Then later on, the P plat was also increasing. Let's see why. So why is so? Before we move on, we need to understand something called resistance. Okay. So what is resistance? You know that resistance is the pressure difference in the pressure required to generate the flow in a system. So resistance is always offered by the upper airway. Okay. Any flow happens here depending on the length of the tube. There is a pressure is required, and that flow will happen. Sorry, the flow will happen. So any pressure required, change in the pressure divided by the flow is nothing but resistance. Resistance is always applicable to the airways. It could be upper airway or the lower airway. The maximum resistance generally happens in the upper airway. So if the radius is normal or length of the tube is small, the or laminar flow, the resistance is very least. So the air flows naturally due to pressure difference. Suppose in any conditions, like the resistance is least when the flow is almost laminar, but in any condition, if there is any spasm in the tube, if you have ventilated a patient, you can see that the endotracheal tube, there are mucus plug, then the resistance increases. There are secretions, then the resistance increases. Suppose the tube is very small, the resistance increases, or the tube is small in diameter, resistance will be high, or the lengthy tube also resistance will be high. So remember, if you want to have a good normal flow, one need to take care of spasm, secretion, edema, or a longer narrative, which all increases, causes turbulent flow and increases the resistance. So and the narrow laminar flow, its resistance is least when the flow is laminar. Okay. When generally what happens when the baby starts crying, then also the resistance will increase. The tube becomes the upper airway becomes narrow. There can be some spasm, and we already discussed the resistance inversely proportional to fourth power of radius. So always when we say that even in pediatric advanced life support, we teach you to give oxygen in a non-life-threatening manner, because even whenever a child starts crying, the resistance will increase and the flow diminishes. So remember these points. So what is a diseased lung which can cause the increased resistance? So any condition if you are dealing with which causes airway obstruction. It could be upper airway obstruction as we discussed, like edema, secretion spasm, or lower airway obstruction like what we saw in that child, like bronchial asthma or a bronchiolitis condition. So in such patient, the resistance is very, very high. So what happens in a PV loop? This is a pressure volume loop. Okay, so more and more, all this will be discussed in the subsequent classes. But just remember, you must have seen such a graph in the when you're connected to the ventilator. So the x-axis is P pressure, the y-axis volume. So this is a normal PV loop. If the resistance is normal, can you see that this is a normal PV loop, the pink one. When the resistance is more, so you can see that the PV loop is almost bulged or distended. So this again conditions as we already discussed, upper airway obstruction or lower airway obstruction like bronchial asthma or bronchiolitis. So we understood resistance, right? So remember, whenever you're dealing, or in case if you happen to intubate or ventilate bronchiolitis or bronchial asthma children, it is always to do with high resistance. So you need to take measures to decrease resistance. How do we do that? So upper airway obstruction secretions you need to take care. If the lower airway obstruction, so one has to administer bronchodilators. Okay, having understood on resistance, let's move on to compliance. Okay, so this is a 15-year-old girl who presented with fever, cough, cold. This child was intubated and see the X-ray. The first X-ray you saw, right? The lungs were very good, but it was hyperinflated, and the child had history of wheezing. So that was a case of bronchial asthma, high resistance. Okay, the airway related to upper airway, lower airway obstruction. Here, can you see this X-ray? So one can say the X-ray is a completely white out bronchopneumonia. This child, by looking at the X-ray itself, we can say that this is a hypoxemic respiratory failure. There are hardly any lungs visible here, right? So now we'll come on to compliance. What is this compliance? Compliance is nothing but the compliance of a lung is defined as change in the volume per unit change in the pressure. So whenever we give, like for example, when we blow a balloon, isn't it? We blow a balloon, that is the pressure. With some pressure, you blow a balloon and the balloon inflates. So there is, when you blow a balloon with the pressure, that is a change in the pressure. When the balloon inflates, there is a change in the volume. So how big the balloon can inflate depending on whether it's a thick balloon or it's a thin balloon, isn't it? So change in the volume for a given change in the pressure, that is nothing but compliance. Okay, so what happens? Let's see. The same I want to take you to this pressure volume curve. Can you see the x-axis is pressure and the y-axis is volume. So what happens? This is a normal beautiful curve. Can you see inhalation and exhalation? Whenever the pressure is changing, the volume is also increasing. Beyond one point, it stops. And the inhalation, as exhalation happens. As I said, inhalation is always active, exhalation is always passive, even in the mechanical ventilation. So this is the normal PV loop. So what happens when the when the compliance is increased? It almost stands erect. Can you see that? This stands erect. So in a condition where the compliance is decreased, so it starts sleeping. It starts reaching towards the pressure slope. Okay. So the green is normal, the yellow is increased resistance, and the pink one is decreased. Remember, whenever the PV loop is almost flat or it is decreasing or touching or going closer towards the pressure axis, then the compliance is decreased. So conditions like ARDS, bronchopneumonia, severe pneumonia, pulmonary edema, they all have reduced compliance. Whereas bronchial asthma, bronchiolitis, or sometimes when you start using higher PEEP, the compliance will start, or there you can appreciate a beaking. That means the compliance is very, very high. You may have to bring down the pressure. So remember these two things. One, we have dealt with resistance. Second is compliance. Compliance is nothing but change in the volume for a given change in the pressure. Remember the balloon, okay? When we inflate, we give some pressure and the balloon starts inflating. That is nothing but how much it inflates depends on the compliance of the balloon. Lungs are similar to that. When you saw, for example, in this patient, you saw that. See this, there are hardly any lungs. This will require high pressure or low pressure. The lungs are very, very bad, isn't it? The compliance is very, very high. The compliance is very, very reduced. The lungs are very stiff. It's almost like a sponge. So one requires a high pressure to inflate this lung, isn't it? For the lung to expand. So that is the reason why the peak inspiratory pressure in this particular child is increased. Okay, so let's see this. So we have understood so far. Whenever you look at the PV loop, first is the clinical X-ray and come back to the ventilation. It gives a lot of information when you look at the graphics. Okay, so you need to remember certain condition. Let's, there are a couple of scenarios here. See, when we talk this, consider this is upper airway and consider this is a lungs. Okay, as I said, like lungs are nothing but like a balloon with a straw or a pipe which is attached. So resistance is always offered by the upper airway and compliance is by the lung part. So here you can see the lungs are normal. the airway is normal and the lungs are normal, the chest X-ray is good. Okay, so you hardly require some pressure to give for the lungs to inflate. Okay, next condition. Here, the upper airway seems to be normal, but the compliance is reduced. So, didn't we discuss this condition? See that X-ray, understand? So, the X-rays are pretty bad. This is pneumonia, where the compliance is reduced, but the resistance is normal. So, this is the condition with probably bronchopneumonia going on for ARDS. You might have to give higher pressure. So, here can you see that resistance is increased. The tubes are very small, thin, or there can be some obstruction. So where the resistance is very high, but the compliance is normal. So this is a scenario which we discussed, isn't it? That patient, that 4-year-old child with hyperinflated lung is a known case of Wheezer. So basically, you're dealing with a resistance-related problem, where this is because of bronchospasm, increased secretion. So the treatment for this condition is bronchodilators. Yes, in the case of impending respiratory failure, one may have to consider intubation. Whereas in this particular, early positive pressure ventilation is what is recommended. So you may have to start off with HFNC to begin with, and later on if the child doesn't tolerate it or doesn't improve within a matter of 1 or 2 hours, then go on to NIV or consider early intubation. Whereas here, where the resistance is very, very bad, you have to take all the measure to reduce the resistance, like administered bronchodilators, back-to-back nebulization, steroids, take care of the secretion. So very rarely you will have both resistance and compliance related. Okay, this could be in probably a known case of Wheezer who develops a bronchial bronchopneumonia going on for ARDS, especially in this flu season. You must have seen lot of wheezing cases getting admitted in the ward or ICU, and they also have viral pneumonia, very bad pneumonia. So remember, so far so good, resistance and compliance. One need to understand the last component, that is the time constant. What is this time constant? It is the time taken, the amount of time taken by the lung unit to fill up during inhalation completely. See, we are inhaling and whatever the gas we are inhaling, that has to reach to the terminal alveoli, isn't it, for the gas exchange to happen. So time constant is nothing but amount of time taken by the lung unit to fill during inhalation or empty during exhalation completely. It should be complete. Suppose you start with 0%. So for the peripheral lung, it is 99.93%. So, and that is the lung unit should fill up completely. Exhalation also from the peripheral lung units, it has to come back to 0% or it has come back to 100%. So why we need to understand the time constant is, each time constant is normally around some 0.15 seconds. So it requires 3 to 5 time constant for lung to completely fill up or completely to exhale. Okay, so it is nothing but product of resistance and compliance. Any problem with resistance, the time constant differs. Likewise, even any change in the compliance, the time constant will be different. Okay, so one need to understand this. As I said, one time constant is 0.15 seconds. So normally 3 to 5 time constants is required for the lung to fill up completely or exhale completely. Okay. Okay. So what is this physiology behind this? Why do we need to know compliance, resistance, or time constant? Because whenever we ventilate, we need to understand, are we dealing with a normal lung or a diseased lung or a patient with bronchopneumonia or a patient with a bronchial asthma. So as this is that child where the problem is, you can see here, this is a compliance related problem. So these children are breathing at a higher rate, isn't it? Very tachypneic, and they are hypoxemic. So what happens? Their time constant is, the alveolus are so small, it will fill up rapidly, and they will exhale. So, but treatment is, and they suffer with hypoxemia. So one has to increase the eye time. I'll come to all of this, okay? So whereas in bronchial asthma, that you know that in bronchial asthma they have got prolonged exhalation. So in case if you ventilate, you have to keep the E time, or you have to keep the low rates and allow them to exhale for a longer duration of time. Okay, so we'll come back to all of this, how to set this. So we have understood all this, isn't it? How lungs are naturally ventilated. Once you attach to a mechanical ventilator, we are mimicking the normal respiratory physiology like trigger, limit, and cycling. Before we put any patient on mechanical ventilation, we need to understand, are we dealing with a normal lung, or are we dealing with a lung which has got pneumonia and ARDS like compliance related problem, or a bronchial asthma, a child where the resistance related problem. Then only we can set up the ventilator. Okay, so how are we going to set any ventilator? So before that, we need to understand there is some pressure. You must have heard, isn't it, in the bedside round when you're working in the ICUs and all, whenever any PG or fellow presenting to the consultant, they say this is the SIMV PRVC mode. This is a pressure control mode or a volume control mode. You must have heard this every now and then when you're working in the ICU, isn't it? Let's understand what is this pressure, volume, and flow mean. Same scenario will take, right? Okay, so the 15-year-old girl who presented with very bad pneumonia, as you can see, and then, the ventilators are alarming, the PIP, the peak pressure is going as high up to 38. If you can see, this patient was set on SIMV, PC mode, that is pressure control mode, the PIP of 28 and the PEEP of 12. This is pretty high PEEP. Okay? Normally, one sets around 5 to 6 PEEP. With this, the saturation is just 94% with 100% of oxygen. And the ventilator will start alarming. Let's see this. So, one need to understand what is this pressure. Pressure is nothing but, as we already discussed, ventilator works on 4 basic parameters. Any change in the pressure causes the flow to happen, right? So, when we are talking about pressure on the ventilator, there are certain terminologies you have to understand. Like, first is peak inspiratory pressure, second is positive end expiratory pressure, and the thirdly, mean airway pressure and plateau pressure. Let's look at one by one. Okay. So, yes. My slides are not moving.
We are on terminology airway pressure, ma'am. We are on the terminology airway pressure slide. Your icon is
moving. But it is not moving. I wonder why. Not moving.
Reload once again, ma'am.
Recording stopped.
I'll share again. Again, it is not moving.
Something.
Yeah. It's moving, right?
Recording in progress.
Okay, so let's understand what is this positive peak inspiratory pressure, the PIP, positive end expiratory pressure, that is PEP, and there's something called plateau pressure, and then the mean airway pressure. This is the whole area under the curve. So the peak inspiratory pressure at the end of inspiration, how much pressure maximum it is reached, that is the peak inspiratory pressure. Positive end expiratory pressure, that is, you can see it is not starting from the baseline. That is because of there is some positive end expiratory pressure always which is present, and that's when the pressure curve is starting from not from 0. It is maybe some 2, 3, whatever you have setting, and this whole area under the curve is mean airway pressure. So why we need to understand? Because this mean airway pressure is the one which determines the oxygenation. There is some formula you can remember or you can take it down. So mean airway pressure is nothing but TI, that is inspiratory time. This is the inspiratory time. T is exhalation time. So TI is inspiratory time into PIP plus exhalation time into your exhalation time into PEP, the whole divided by breath cycle. TI plus TE, the complete respiratory cycle, which is nothing but it's a addition of inspiratory time for expiratory time. So why we need to understand MAP is because if you want to improve oxygenation, one has to improve the MAP. Okay, how to improve the MAP? We'll see in the subsequent slides. So PIP, your peak inspiratory time, is the pressure at the end of inspiration. Pressure needed to deliver the flow into alveoli it is all work against the resistance and elasticity or compliance. There's something called plateau pressure when there is no flow. That is, when the flow becomes zero in end inspiration, this represents to alveolar pressure. No flow means no resistance. I will show it in this particular. So, okay. So this we know, right? Here it is PEP, positive and expiratory pressure, PIP. Then the inhalation stops and there will be some phase when there is no flow. The pressure almost drops. This is your plateau pressure, which is nothing but alveolar distending pressure or through pulmonary pressure. Okay, so this is one beautiful picture. If you can see how the mechanical ventilation works. See, for example, initially the pressure time scalar is a reflection of pressure generated within the airway during each cycle. So at the beginning of inspiratory cycle, the ventilator has to generate the pressure. Can you see it has to generate the pressure to overcome the airway resistance? Where is the airway resistance? Air resistance is always offered by the air greater rather larger airways. So that is where to overcome. So there is no volume is delivered at this time. So what happens next at this? Then the pressure rises in a linear fashion and this finally reaches the peak inspiratory pressure. So at this time, the lung expands. Then there is a no flow state, that is nothing but your plateau pressure. The pressure drops by an amount equal to the respiratory pressure, which is a plateau pressure, and it returns to normal. Okay. So remember, when you're talking about pressure, one has to understand peak inspiratory pressure. This is the one. Okay. When there is no flow, this is the plateau pressure. Okay. The positive end expiratory pressure, here there is zero PEEP. That's why it is starting from the baseline. Otherwise, when you set PEEP, it is always starts from here. Why we need to understand all this PIP, P plat and all? There are certain conditions. Can you see that normally there will be a difference of 3, 4, whatever set PIP and plat normally. There is certain difference. But this difference increases. For example, when you're dealing a child with bronchial asthma, you can see that the PIP is very, very high. The P plat is almost normal. Okay. So how do we get to measure this P plat? By keeping an inspiratory hold. In the subsequent classes, when you're dealing with diseased lung, we will teach you how to measure this P plat. Just understand this. There's something called PIP and P plat. If this difference is high, no, you might be dealing a patient with airway resistance. Suppose both the PIP and the P plat both
Recording in progress.
This positive end expiratory pressure, as I said, it will never start from the PV loop or your pressure loop never starts from zero. If it starts, means there is no PEEP. There is low compliance. As you can see here, when you give some PEEP, a 5 centimeter of PEEP, it almost stands erect. The lung will start expanding. PEEP is required to keep the lung open and to prevent lung from collapsing. So it is open the lung and keeps it open, or open the alveoli and keeps it open. That's why the PEEP is required. It recruits the alveoli and improves the ventilation perfusion mismatch. And further, it improves the oxygenation. Also, it maintains the functional residual capacity and keep the pulmonary vascular resistance at a low. So one need to remember that we have to give some optimum PEEP. What is that optimum PEEP? Optimum PEEP is nothing but minimum PEEP required to prevent any end expiratory collapse. Normally as I said, when lungs are like balloon, you are giving some pressure, it inflates, isn't it? When you no longer give pressure, it all collapses, isn't it? When you just stop inflating the balloon, it collapses, isn't it? So to avoid that collapse, one has to keep some positive end expiratory pressure. So it prevents the end expiratory alveolar collapse that are aerated at end inspiration. But how much you have to keep? Shouldn't keep too much of high PEEP, where the lungs almost will start over distended and can cause trauma. So that PEEP which is optimum PEEP, or that will keep the alveolar to collapse, opens the alveoli and prevents the alveolar collapse, that's when we have to titrate the PEEP. That's the safe zone. How to titrate PEEP? Again, all this will be taught in your subsequent classes. So remember, PEEP, one has to set an optimum PEEP. Normally, we set a PEEP of around 5 to 6 in normal lung. Okay, so this is the optimum PEEP. So applying all this physiology, we understood, right? OPIP, PEP or plateau pressure. So why we need to understand is whenever you are dealing with a patient with hypoxemia, what are the factors? Oxygenation is nothing but if you have to improve the oxygenation, one has to increase the FiO2. And we discussed mean airway pressure also has to be increased. So factors that decide mean airway pressure, we remember this formula. So if you want to improve oxygenation, then you have to improve your mean airway pressure. So these are the factors to improve the mean airway pressure, like optimum PEEP, increase PIP, inspiratory time, inhalation time, and flow. At least you can increase the PEP and inhalation time. These are the factors. So you understood pressure. Let's move on to gas volume. Volume is nothing but you remember this normal respiratory lung volumes, isn't it? Tidal volume, that is inhalation of gas or movement of gas during normal respiration. So even in mechanical ventilation, one has to ventilate at a normal tidal volume. So this is your volume versus time curve in the scalas. So this is how it looks like. The y-axis is volume, the x-axis is time. The normal tidal, how much tidal volume we have to set? 6 to 8 ml per kilo body weight. In children, it's always per kilo body weight, should be targeted for normal lung. So why we need to understand this volume is it determines the ventilation. Suppose if you want to improve the carbon dioxide or you want to got the carbon dioxide to wash out, one has to increase the rate, isn't it? When we breathe very fast, the carbon dioxide gets washed out. Similarly, in mechanical ventilation, if you want to take care of CO2, one has to increase the rate. Secondly, you have to increase the tidal volume. Then gas flow. Gas flow is almost movement of gas volume over a time. It is almost equated with volume. So higher the flow, higher the volume. So with higher flow rate will produce greater volume change in the same time. There is remember that in ventilation, it is some bias flow is always there at the background. Okay. So if you want to increase the volume, you have to increase the flow. Okay. So this is the loop. So normal respiration. We'll talk about how when normal respiration or a spontaneous breath looks like in a mechanical ventilation, how a mechanical breath is displayed in a graphic. So this is a normal spontaneous breath in mechanical ventilation. Okay. Suppose the same mechanical breath, this is the flow. Okay, as I said, flow. So this is flow y-axis and the time. As you can see, the inspiration will start. Exhalation is always passive. Can you see that this sort of graph you would have seen? The flow curve will always have positive and the negative deflection. Negative is nothing but expiration. So this is a mechanical breath. This is a spontaneous breath. So the flow pattern, it can be square wave pattern. It can be decelerating pattern, sometimes accelerating and sinusoidal, right? So square wave pattern, remember this sort of pattern you will see in volume control mode, where the flow and volume we are equating. So flow is always fixed. Okay, that is in volume control. Whereas in pressure control mode, it is always decelerating pattern. Okay, so to recapitulate, the factors that determines oxygenation is all of this. You have to improve FiO2, mean airway pressure by increasing the PEEP and I time. Ventilation is your nothing but minute ventilation, which is a product of tidal volume, respiratory rate, and exhalation time. So, is it very confusing? I've spoken so much about rate, PIP, P-plat, and all of this. Yes, in whenever this may not be new, but remember, whenever you are setting PIP, P-plat, always remember, you have to remember whether you're dealing with a compliance or a resistance related problem. Okay, then lastly we'll come to modes of ventilation. How do you describe the different modes of ventilation? A mode is nothing but a way or manner in which something occur, express, experience or done. So what are these different modes? This slide I am coming back again and again, as I said, because this is one of these beautiful slides to compare between the normal respiratory physiology and mechanical ventilation. That we understood trigger, TLC, trigger, limit and cycling. Trigger is that something initiate. Limit is where the inhalation gets limited. Cycling is inhalation stops and the exhalation starts, isn't it? So even in mechanical ventilation, 3 questions needs to be asked to understand the modes of ventilation. Who is initiating the inspiration? Normally, in respiratory physiology, natural lung, the brain is the one who is giving the signal, isn't it? But here, there is either it's a pressure trigger or a flow trigger. We'll understand that. Second question is, how far is the inspiration allowed, or what is the limit for inspiration? Third question we need to answer is inhalation stops and exhalation starts. So TELC, remember this. So these are the different phases. Trigger could be time triggered. You know, you have set 30 breaths per minute. That means every 2 seconds, one breath is triggered. The machine gives a breath. That is time triggered. Or some change in the pressure or change in the flow. When a patient, suppose in case of assist control or SIMB, you will have to set a pressure or a flow. That is whenever the ventilator senses the patient, there is a change in the flow, it triggers a breath. Limit is always either if in a pressure control, it is a pressure is the limit. In volume control, set tidal volume is the limit. Okay. And cycling. Cycling is again, it's a passive phenomenon. Here, these variables facilitate transition between inspiration and exhalation. So the control variables are something which you set. Like for example, in pressure limited, you are going to set the pressure. In volume, you are going to set the volume. The pressure will vary. In pressure is set, volume will vary. Okay. There is the other newer modes like dual mode, pressure regulated volume control. Okay. The dual mode and spontaneous mode. So what is this pressure limited? As I said, you are going to set the pressure, the volume varies. So volume can be high or low. So as a result, these children can develop volume trauma, isn't it? Likewise, in volume limited, you are going to set the tidal volume, but the pressure will vary and they are prone for barotrauma. So to combat these two, you got something newer modes like pressure regulated volume control mode. Let's look at each one of them. So this is the front part of the ventilator. So you must have seen this. You must have been familiar with this part of the picture of ventilator. So there is a mode here. You can choose whenever you start, you can choose which mode you're going to set. And these are the preset variables and alarms. So like FiO2, you may have to start with 100%. And then there is a respiratory rate. Then PEEP, this is the PEP. This is the PIP. So like that, there are preset thing. So this is a pressure mode. So you're setting all this pressure. I think this is PIP, this is PIP, PEP, and this is the respiratory rate, and start with 100%. And this is outcome. As I said, in pressure control, the volume varies. So this outcome, like tidal volume, keeps on varying with each breath. Okay. So there are other knobs like inspiratory hold, expiratory hold, and this is for the alarm setting. Right. What are the functions of each of these? When we are discussing the disease pathology, we will show you what to measure when we do expiratory hold or when we have to do an inspiratory hold. Okay. So let's understand a few more things. You know, as I said, that trigger, limit, and cycling. What happens in case if a machine does all this work? That is, machine is starting the inhalation, and the inhalation is limited at set volume or a pressure. And inhalation it stops and the exhalation starts. Everything is done by the machine. It is called mandatory breath. Okay. For example, CMV, controlled mandatory ventilation. In CMV mode, everything is done by the machine. Generally, we don't use such mode unless the patient is neurologically weak, like if you're dealing with a Guillain-Barré syndrome or peripheral neuropathy where the patient is absolutely not breathing, then only you apply CMV mode. Suppose patient is doing all the work. Patient is only triggering, limiting the inhalation, and the inhalation stop and cycling starts off to exhalation. In a ventilated patient, that is called spontaneous breath, like your continuous positive airway pressure. Like CPAP mode, patient is only doing all the trigger, limit, and cycling. Suppose only trigger is done by the patient. Patient just triggers. Rest of the thing, like limit and cycling, is done by the ventilator. That is called assist control. Okay. So remember these three modes. Okay. So first is mandatory, where everything is done by the patient. The machine, that is mandatory. Everything is done by the patient, is spontaneous. In assist, only the trigger part is done by the patient. Rest of the things are done by the machine. Okay. So this is what I was mentioning, control mode. For example, if you have set a pressure control mode, it is triggered by the time. Okay, and the pressure limit, time cycle. At every 2 seconds, inhalation stop and exhalation starts. Okay, the next breath starts, right? So this is the control mode of ventilation. So let's look at this assist. Assist, what I said? I said the patient is triggering the bell. Whenever there is a trigger happening by the patient, it is always starts off with a negative action. Can you see here? Negative. Whereas the previous, there is no triggered by the patient, everything's done by the machine. Whereas in assist control, there is a trigger, negative deflection, patient start triggering, but rest of the things, is taken care by the ventilation, limit as well as cycling. So can you see this time cycle? Okay, so this is patient triggered, pressure limited and time cycle. So there is an these assist control and control mode of ventilation is almost it's become obsolete. More or less we use SIMV. What happens is SIMV or IMV? IM is intermittent mandatory ventilation. This is the patient machine triggered breath. Intermittently patient is also breathing, right? This is intermittent mandatory ventilation. But if you want to synchronize with the patient's breath, suppose machine is giving a breath at a set rate and intermittently, suppose the patient is breathing, machine senses and will not give any breath during that time. Okay. So synchronized intermittent mandatory ventilation is when the machine sensor, the patient is taking a spontaneous breath and it will give some supported breath at the preset volume. Okay. So this is how the ventilator will look like. Yes, this is synchronized intermittent mandatory ventilation. Volume control. This is a volume is what you are going to set, like tidal volume, which is 6 to 8 ml per kilo. Can you see that? And this is your pressure, flow, and the volume. Okay, the flow is always square. Can you see the square? The fixed tidal volume, the pressure keeps on varying. Okay, so similarly, you got SIMV pressure control mode, where it is you have got a preset pressure. You are setting up pressure control around 12, but the tidal volume, if this is a pressure control, your flow is decelerating, the volume keeps on varying. Okay, so remember the SIMV pressure control or SIMV volume control. See, the other common mode of ventilation is used in a weaning patient. When you are weaning from mechanical ventilation is CPAP, that is continuous positive airway pressure, where everything is done by the pressure, the patient is triggering, limiting at whatever the pressure and the cycling is happening. So, okay, so this is a CPAP mode. There is no rate. You're not giving any rate here. So you're just setting some CPAP or pressure control and the patient is doing everything here. Okay, so as I said, the pressure limited, these patients are risk for volume trauma. In volume limited, they are risk for pressure trauma. If you want to overcome these two, one can choose PRVC mode. So the PRVC mode is nothing but pressure regulated and volume control, where it assured volume it's given at a minimum pressure. So this is again the newer modes most commonly used, where you're going to set the tidal volume and I time. You're not going to set a pressure. The machine delivers a breath and adjusts the flow and pattern to minimum. At the low pressure, it delivers the set tidal volume. Okay, it senses it measures the compliance. It senses how much pressure is required to inflate the lung, delivers that much pressure. And suppose compliance changes, it readjusts it to minimum pressure required for tidal volume, set tidal volume. This is nothing but closed loop ventilation. These are the newer modes which this is your PRVC. As we can see, we are pressure regulated. The machine itself the pressure and delivers the tidal volume at the minimum pressure. Whatever set tidal volume, it is delivered at a minimum pressure. But once you do this, remember, you have to set the alarm. Okay. So is this confusing? You understood? We went on from natural ventilation to mechanical ventilation to different types of terminologies like resistance compliance, and now we have come to different modes. Most common used mode is your SIMV. Either it could be SIMV PS or SIMV PRVC. But before setting all this, you need to understand something called trigger, limit, and cycling. So troubleshooting, there are only a couple of slides. I wanted to show you how to set up a ventilator. There's a video, very beautiful video. Troubleshooting itself is a big talk, but I'll just give a touch upon this troubleshooting. This is a PV loop. This is a normal PV loop, and this is the normal flow volume loop. Suppose if there is any air leak, suppose if you have inserted any small tube, you can see that PV loop, it is not touching the baseline. That means the tubes are very small, everything is leaking. You may have to rechange the tube. Okay. The air leak even under this is a flow volume loop. This is how it looks like. So it doesn't touch the baseline. Okay. Yeah. So we'll take a detailed class on the air traffic, but I'll just touch upon. So suppose if air trapping means like bronchial asthma, a lot of air trapping is happening. Can you see exhalation is not touching the baseline? So the treatment is here is bronchodilators. Lot of secretions. You will be seeing that there are a lot of secretion. That is how it looks like a ragged appearance. So secretions are not to take. So setting up of a ventilator, remember some machine, when mechanical ventilator is an automatic machine doing either a partial or a complete work of breathing. So what you set is either pressure or a volume. In the pressure, PIP or PEP. Or if you're setting the volume, your tidal volume is what you setting. You also setting I time and E time. But everything is influenced by if you're dealing with a normal lung or a lung with high resistance or a low compliance. Remember, that is what will determine what pressure, what volume you're supposed to set. And it is just a support. Remember, ventilator is just a support. It is not a cure at all. You need to treat the underlying physiology. One has to have a good understanding of mechanical basics of mechanical ventilation and what lung are you ventilating. Otherwise, it can be disaster. Okay. So yes, that is the end of my talk. But I just wanted to show you a video here. Nitin, do you have time? I have a video.
We have 5 more minutes, ma'am. We can definitely show the video, no problem.
So yes, if you can see this, I'll share this link in the group. Okay. So this is a video. Oh my God, sorry. It's coming. Sorry. It's coming. I'm sorry to skip. Okay, this is from Open Pediatrics. Okay. So
how to attach the components of deliver humidity to the patient.
Please share your screen once.
sorry.
The tubing is either disposable.
Recording stopped.
If it's disposable, it will be thrown away after each patient use. If it's non-disposable, it will be sent to be cleaned. The inspiratory end of the ventilator is connected to the humidifier. The expiratory end is connected to that.
Recording in progress.
And there is a piece of tubing that goes from the
Full screen, please. Yeah.
end of the ventilator to the top of the humidifier.
Is it shared?
The circuit
Yeah,
then
it's visible, ma'am. Make it full screen, please.
temperature probe
1 second.
for use with the humidifier,
Yeah.
which monitors
No,
the
ma'am.
temperature
No.
back at
Recording stopped.
Ma'am, we can
1 second.
share the link. Yeah.
Yeah, I think that is better. I'll share
Sure.
the link. 1 second. 1 second. 1 second. There is one last video which maybe I think this would be better. I'll share that Open Pediatrics link. Yes. So whenever you're connecting to a ventilator, you have to connect to gas flow. Here,
Recording in progress.
the oxygen here, as you can see. And we have a Maca ventilator, so I'm showing how to set up in a Maca ventilator. This is the front part of the screen. This is where you keep the humidifier here. So always you need to start, it will be in a standby mode. You need to select the mode and you should start with the pre-test. Okay, so pre-test, you have to connect there are tubings which you have to connect and start with the pre-test. So there are methods to do this pre-test. So you have to connect that inhalation, exhalation and start with the pre-test here. And setting on the tubings. The tubing is, nowadays there is heated wire disposable tubing. This is heated wire non-disposable tubings, but many of, most of us are using this disposable tubings. So it is like any procedure. So you have to take as aseptic precaution as possible. Okay, select the appropriate size tubing. For infant or a small toddler, you will have a pediatric tubing. For a bigger patient, you have an adult tubing. Okay. So you can have to choose the size of the tubing is very, very important. You cannot be using a bigger tubing for a smaller baby. Okay, so that is the humidifier. We have to add distilled water, which is a newly opened distilled water. Okay, so the humidifier is attached to this particular section. Okay, and now the nurse is taking the wires. The one connection, but this part of the humidifier goes to the ventilator. You can see, yes, here this is how we are going to connect. Yeah, this is the inhalation and exhalation wheel. Currently, most of us are using either Fisher, Frakel or other brand. The tubing color is different. If it is inhalation, means it is blue port. The exhalation is white port. Okay, I will say share the link of the Open Pediatric. It narrates beautifully how they connect the inhalation and exhalation. Okay. See, as you can see, this is the one part of the tubing. That's the inhalation, which is attached to the humidifier. This is the exhalation part, which is attached here. And this is the Y piece. These are the heated wire. So whenever you are connected to the humidifier, make sure you always connect it to heated wire, the temperature probe. So one has to set the heated wire to, or set the humidifier temperature as around some 36.5 to 36.8. So this is where you connect the heated wire to the proximal end. This has to be cleaned. That is how the temperature probe is connected. Can you see here? There is one is to the humidifier chamber, this with this outlet, and other one is connected to the Y connector. There is a port there. That is where you connect your temperature. So that senses the temperature, and there are heated wire inside this temperature, and this goes to the endotracheal tube. So remember, these are the parts of setting up of the ventilator. Yeah, that brings
There are 1 to 2.
Sorry.
One question is there, ma'am, by Dr. Mossy. He wants to ask why P peak and P flat increased in the first case. I think you have already covered it in your graphical representation of P peak and P flat.
Yeah. So see, normally the PIP. So in a pressure control, we set PIP. That is a peak inspiratory pressure. And the P flats are not set. It is measured. So the PIP, suppose you have set up pressure, volume control mode. You know that in volume control, the pressures vary. So when you set up a volume control, if your PIP is going to 20, 25 or 28, it is increasing. Okay, then one has to check the inspiratory hold and check for P flat. Once you do an inspiratory hold for 2 to 3 seconds, there is a P flat gets displayed. So normally, if PIP is around some 28 and P flat is around 20 P flat is normal. That gap is higher means you are dealing in a patient with a lung air trapping, like increased resistance. Suppose PIP is 28 and P flat is also 26. That means the lungs are pretty bad. It's solid lungs. So you're dealing a condition with decreased compliance. Okay.
The second question is how to select best time and TE.
Okay. See, the selection of time, see, when you set a ventilator, respiratory rate is what you set. So how do you set a respiratory rate? Depending on the diseased lung. If you're intubating a patient with status epilepticus where lungs are absolutely fine. Suppose 2-year-old child, the child comes with status and not maintaining saturation, you happen to intubate, lungs are good. So how much respiratory rate you set in? Then respiratory rate is normal physiological respiratory rate of 2-year-old is around some 25, 28. That much only you set, isn't it? Suppose you set a rate of 30. That means every 2 seconds, one breath is delivered. So there is something called IE ratio. So IE ratio is generally 1:2. Normally, we inhale and we exhale, isn't it? So 1:2. That means every 2 seconds, the one breath is delivered. In that 2 seconds, if it is 1:2 means 0.3, it will be around 0.5 to 0.6 is inhalation, 1.4 second, 0.6 to 0.7 is inhalation time, 1.4 second is exhalation time. You have to again divide in that 2 seconds. The 1:2, isn't it? So 0.6 to 0.7 is inhalation. Then the remaining 0.6 minus 2 is around 1.4, or 0.6 into 2 is 1.2, isn't it? So 1.6 to 0.7 is your inhalation. So what happens? Suppose if you want higher inhalation time, what you do is you set your breath cycle is 1:2, but keep the low rates. For example, suppose you set the same instead of 30, if you set 20, that means every 3 seconds you're giving one breath, isn't it? That again 1:2 of that will be around every 3 seconds means 1 minute, 1 second will be inhalation, remaining 2 seconds is exhalation. So that's how you set your inhalation or exhalation time. So remember, normally you set 1:2. Your rate you have to increase, decrease. You go to your ventilator and you see that what happens to your I time. It displays. Once you set your rate, suppose you are setting a rate at 40, that means 1.5 seconds you are giving one breath. In that, I time decreases, isn't it? 1:2 means maybe 0.5 second is your inhalation, remaining 1 second will be your exhalation, like that. Okay. So what should be the normal TI is 0.6 to 0.7 seconds. That's why we don't set too high rates. If you set very high rate of 40, 50, item decreases. Item decreases means oxygenation will be affected. So you'll always set maybe 30, 25 to 30. Okay. Okay, the other question is trigger sensitivity. Trigger is, as I said, that which initiates the breath. Normally, in all the ventilator, it can be either a pressure trigger or a flow trigger. Suppose we inhale the breath, suppose if there is a mechanical ventilation, in the tubings, no, there will be, the ventilator senses there is drop in the pressure. Suppose if you have set up pressure trigger means pressure is always negative, isn't it? Inhalation is always starts with a negative pressure. So if you would have set -1, -2, -3, so the ventilator senses that from -1 there is a drop in the pressure to -3 and it delivers a breath. There is other trigger, that is flow trigger. So you would have set 3, 4. So ventilator senses the change in the flow. So always remember to set a flow trigger because that is takes less effort on the patient to trigger a breath. Pressure trigger is not used at all. It is always a flow trigger which is used. How to prevent beaking? Okay, beaking, as I said, if you are giving too much of pressure, the PV loops will start beaking. That means you may have to come down on the pressure, you may have to come down on your positive and expiratory pressure. Okay, depending on what lung you are dealing with. Today's class is to understand how a ventilator works. There are certain terminologies. I'm sorry to bombard with all these terminologies, but one has to understand or remember those terminologies. As and when we move on to the subsequent classes, it becomes much more clearer. Okay, what is this PIP? What is this PEP? Suddenly she's telling about P-plat, rates and all. So remember, mode is what? Ventilator and respiration is almost similar. What we set on whenever we attach this patient mechanical ventilation, we are mimicking normal respiratory physiology. And always remember, we are not ventilating a normal lung, isn't it? Sometimes a bronchopneumonia, sometimes bronchial asthma, sometimes status epilepticus with normal lungs. So for all of them, there is no one answer. Okay, so each you have to remember what type of lung are you ventilating to know the settings. What is ATC? I didn't say ATC. I don't know. Maybe they can be clear. This last person whoever has asked, what is ATC? I didn't tell anything about ATC. I think so far so good. I will share that link of Open Pediatrics, setting of ventilator, what the front part of the ventilator, everything will be. It's narrated beautifully in that Open Pediatrics video. Okay, it's a YouTube video, free access. You can just watch it before you come back for the next class.
And with no other questions, I think we will close this session.
Sure.
And in case any of the participant has any question, then please put it on our AICU Unified group. I'll share it with ma'am and we'll post. Next class will be as per the schedule. And ma'am Dragon mentions it. Dr. P is
Oh.
mentioning. Okay.
Maybe I'll find out. I'm not used to Dragger, but I'll find out and come back in the next class.
Thank you everyone for joining. Thank you, ma'am, for taking out
Thank you
time.
so much.
And
Thank you
it
so
was a
much.
privilege to learn
Yeah.
again, ma'am.
Yeah, thank you so much, Nitin, for this opportunity. Thank you all. Okay, so just remember, be there in the subsequent classes with all of these, and the terminologies will start settling down. Okay, so yes, this is not new for you, but some of the terms, whatever you use, might be confusing, but it will get clarified in the near future classes. Thank you so much. Thanks,
Yes,
Dr. Nitin. Thank you.
Thank you.
Bye. Bye.